अपनी तरफ से म्यूट करने के बोल रहे हैं।
नहीं, ये हमारा पार्टिसिपेंट
my presentation. Show the feedback. We'll have questions for questioning and Good afternoon for those of you who are logging in from South Asia, and good morning from those from Europe, and presumably a very early morning if you are from the Americas and many other parts of the world. So I welcome you to this first in the series of webinars which we are having on smokeless tobacco. I I'm very proud of the fact that I can introduce Dr. Gupta, who many of you, I'm sure, are familiar with. And he's, I think, the ideal person to be the opening batsman in terms of cricket as far as this particular webinar series is concerned. This webinar series is hosted by the WHO FCTC Global Hub for Smokeless Tobacco, which we host here at the ICMR National Institute of Cancer Prevention, which is in the National Capital Region in India. So this hub has been in practice for the last about 2 years or so, and we are very proud of our team, as well as we are indeed grateful to our partners, not only the WHO FCTC, but about 30 to 40 different organizations spread not only in South Asia, but all over the world. And Dr. Gupta represents and is the chief of the Healis-Sekhsaria Institute based out of Bombay in Western India. And he is one of the pioneers as far as tobacco control is concerned. And one of his special interests has been smokeless tobacco, of which he is going to talk about the global prevalence as well as the control measures that are existing at the moment. So it will be the introductory webinar, and I feel probably one of the more important webinars in this series. In the end, I'll be talking about policy. This policy was released earlier in the year, and talk about what are the various policies that are existing at the moment in the world, not only in high burden countries like South Asia, but also other parts of the world. And what are the important issues that we can be handling, and how are the various governments or various parties going to be involved in implementing the control of smokeless tobacco. Those words, without further ado, let me hand over the mic to Dr. Gutka, and I'm sure he'll be able to enlighten us more as far as the current scenario is concerned, and also what are the area of interest. So over to you, Dr. Gutka.
May I request all of you to please mute your systems?
और नहीं यार मजाक कर रहे हैं मैंने पता
May I? No, they it's not possible.
Okay. For those of you who are logging on a cell phone, may I make a request to kindly mute your speaker?
मेरा ना सेमिनार चल रहा है जरा चालू हो गया काम
Yes, thank you so much for muting your speaker. I'll hand over the mic to Dr. Prakash Gupta. Dr. Gupta, please.
Thank you very much, Ravi, for this very kind introduction. I'm really very appreciative of the work that is ongoing in this smokeless tobacco hub designated by the Government of India and in collaboration with WHO FCTC. This has brought a focus, a global focus, which was very necessary on the smokeless tobacco problem. So in my presentation, I would specifically like to talk about the global aspect of the smokeless tobacco products and health effects, and maybe touch upon control issues in the end if time permits, because we have to respect time. So can I have the beginning of the presentation? Yeah. So talk of So we talk about the global scenario and the health impact, and you can see this is first made to show the extent of the problem. You can see that to less extent or more extent, it is there all over the world. In some areas of the world, either there is no information available or the problem is not very common. But we will go into more details later. On the whole in the world, the reason why there is a lack of focus is, as you see in this pie chart, the problem is mostly confined to one Southeast Asia region of the WHO.
Just give us one moment.
Yeah, sure. It is not that it is completely absent in other regions. It is there, but in Southeast Asia and particularly India, it's like it's overwhelming. And the problem really gets compounded by the fact that unlike smoking products, which are very few in number, I mean, cigarette of course completely dominates the entire smoking scenario, and there are some other smoking products. But in smokeless tobacco, there is a huge variety of products. And it is true not only in India, but globally. And this is just a very, very small slice of the kind of products that are available in different parts of the world. India, of course, is there, but then there are like in South America, there are products, then Africa, then there are Middle Eastern products, and to further compound the problems, tobacco industry is bringing out even newer products like tobacco coated toothpicks and orbs. So the problem is complex, is very widespread, and can become even more complex because of the interference of mainstream tobacco industry. Again, unlike smoking, there are so many different ways of using smokeless tobacco. smokeless tobacco product can be chewed. The products that contain tobacco leaves, it can contain other leaves, other agricultural ingredients. It can contain nuts, specifically areca nuts, and it can contain many other condiments and flavoring agents. Then there are products that contain moist powdered tobacco with alkaline agent, and they can be kept in the mouth and sucked like lozenges, and in India, khainil, and even in Europe, the product snus. Then there are products that are in powdered form or in paste form, and those products are applied to generally to teeth and gums. And there are a variety of those products like mishri, that is in Western India, bajja, then budaku in Eastern India, and creamies. And then even there is a liquid product like tobacco water is in the northeastern part of India called quid, and that is used for gargling. People put it in the mouth, keep it for some time, and then spit it out. And inhalation used to be very, very common at one time. Now it is much less common. But very fine dry powder of tobacco can be used as nasal snuff for inhalation. Now, India really is the largest producer and consumer of smokeless tobacco products in the world, as there is a huge variety. And we have now the latest results from the Global Adult Tobacco Survey second round. And there are still about 200 million smokeless tobacco users in India. So it's a huge problem. And annual deaths from smokeless tobacco use in India among non-smokers is estimated as 368,000. We'll go through a little bit more detail on it later on. So these are the varieties of smokeless tobacco products in India. Just a small variety. But actually, if you go to market, you can see many more. And these products, again, in India, they can be user prepared or assembled. The user can buy different ingredients, including tobacco leaves or different forms of tobacco, add ingredients, and make their own product. And like mishri can be made by pyrolyzing tobacco flakes, or betel quid can be lime onto the betel leaf. This is betel quid. Regular users keep all ingredients: green betel leaf, lime, slaked lime, areca nuts, tobacco, their favorite condiments, and they all put together on green betel leaf, food, and chew. And until recently, this used to be the most common way of using smokeless tobacco. But it has changed recently.
Okay, sir.
Then there are custom-made products, because in any place in India, in any inhabited place, you are never very far away from a kiosk that is selling tobacco products. So they can prepare betel quid or any other tobacco product as per your specification, as per your ingredients you like, and as per the proportions you like. So those are custom-made products for a user. Then there are manufactured products that can be locally made and sold on a small scale. And there is a huge variety of those products. It can be oral snuff, it can be mishri, it can be gul, budaku, which is a paste, actually tobacco made with tobacco leaves and molasses, sold in small bottles.
Yes, sir.
And then there are khainil, which is the most common form of tobacco that is used in India. It's a mixture of tobacco and slaked lime that can be rubbed in palm with the help of a finger or a thumb, and you can see this activity going on anywhere in India. You go pass around people and you can see that they are rubbing something on one palm with other thumb. and then you can be sure that they are making candy out of it, and they are going to put that in the mouth. Then there are products that can be targeted towards betel quid vendors to put in betel quid, like kiwam and zarda and patti. They can be used independently also, but often put into betel quid. Then there are products that are manufactured on large industrial scale, and the most common among them is Gutka and pan masala. And it started only in 1980s with a technology of a single-use sachet, and it really took the entire market by storm with the very intensive, focused marketing strategies that were targeted to adolescents and young adults. This has caused a huge amount of health problem in India, and that is why this is the first product. Gutka is the first smokeless, first tobacco product in fact in India that is officially banned by almost all states in India. Very interesting other kinds of product. One I said tobacco water. The other one is tobacco toothpaste. They don't call it toothpaste because of legal restrictions and reasons, but they make no bones about it to make it clear that it is a toothpaste, which can be put on. They can even show it along with a toothbrush to show that this creamy snuff can be used just like toothpaste, and it is used like toothpaste. And with the goodness, they advertise with the goodness of natural tobacco, chew, and clove and mint.
Oh,
Those are the flavors there.
background.
Yeah, according to WHO, now that we know that yesterday was World No Tobacco Day. Everybody, everywhere it got advertised that 7 million deaths annually are attributable to tobacco use. And most of the users are in low and middle income countries. But these are really the deaths that are due to smoking, because that is how it comes in the calculation. But SLT use, as we see, is quite common. It is rising also in many places. And if there is SLT attributable mortality, that will be a matter of major concern. So, and we have to recognize that an estimation of tobacco-related disease burden is incomplete without mentioning or taking into account smokeless tobacco component. So the key findings are that it is a global problem. About 352 million estimated persons use smokeless tobacco, approximately in 121 countries. And majority of them live in low and middle income countries. And it is so common that in many countries, smokeless tobacco use exceeds cigarette use. And other major problem is that it is much more a bigger problem in vulnerable populations, such as youth, women, indigenous population, and special group populations. Generally, in the population, 2/3 of users are male, 1/3 are females. Only 1 in 10 adult males and 1 in 20 adult females use smokeless tobacco. More than 90% of global smokeless tobacco users reside in low-income countries or low and middle-income countries. And it is quite high, significantly higher in rural areas compared to urban areas, especially in Southeast Asia and African regions, and much higher among poor segments of the society compared to rich, again in Southeast Asia and African regions. So, and this burden, you see, is there in practically every country of the Southeast Asia except perhaps Maldives and Timor-Leste. We don't have much information on Timor-Leste. And Thailand, among adults, the burden is somewhat low, but among adolescents, it's there. Nowhere it is less than 5%, and among adults, it's always more than 15% and higher than 20% also. Now, what are the possible health effects? Now, cancer is most well-known, most commonly referred health effects of smokeless tobacco use, and more than 30 carcinogens have been identified in smokeless tobacco. The most prominent is tobacco-specific nitrosamines, but there are other carcinogens identified in the laboratory. And human evidence, confirmatory human evidence is available for oral, esophageal, and pancreatic cancer that has been evaluated by the International Agency for Research on Cancer, and the evidence has been evaluated as sufficient for carcinogenicity. In addition, smokeless tobacco use causes potentially pre-malignant lesions, which are quite common. For example, leukoplegia is very common, most prominent, found among, it can be from less than 1% to 5-6% of population, and it has a malignant transformation rate, which is a pre-malignant lesion. Erythroplakia is even more potentially pre-malignant lesion, which has a higher conversion rate. Oral submucous fibrosis used to be an uncommon condition, but it is now one of the most common pre-malignant condition, especially in India, and it has a high prevalence as well as high malignant conversion rate. These are something that don't get often recognized except those who deal in oral health. Then cardiovascular effects. It is maybe surprising, but like smoking, smokeless tobacco also has definite cardiovascular effect, similar to cigarette. They could be related to nicotine, polycyclic aromatic hydrocarbons, or heavy metals in tobacco products. There are constituents in smokeless tobacco that can cause hypertension. The relationships are have been reported, established. Stroke. That is quite strong evidence that smokeless tobacco consumption is linked with increased risk of fatal ischemic heart disease and stroke with significant relative risks. Other health effects, diabetes and insulin resistance, chronic rhinitis, especially if people are inhaling tobacco in the form of dry snuff, reproductive outcome. I would like to speak a little more about this because these are not very well recognized. And then psychological dependence, of course, it starts at very early age when one starts using smokeless tobacco products. For all-cause mortality, what the relative risks that have been estimated, like the around 1.22. For all cancers, 1.31. Of course, for specific type of cancers, there are more, like oral cancer and esophageal cancer. For upper digestive tract cancer, 2.17. This is a part of all cancer. Stomach cancer, 1.33. Cervical cancer also is related to smokeless tobacco use. Ischemic heart disease and stroke. All these have significant mortality risks from the use of smokeless tobacco. Oh, this is, sorry, you can't see it so well, but this is like a forest plot of all the estimates that are available for all-cause mortality. And you see almost all of them are to the right side of the line, and the overall estimate is 1.22 of all. So we can estimate, given these data, we can estimate the number of deaths that can be attributed to smokeless tobacco use due to all causes, and that estimate comes out to be 652,000 with little wide confidence limit. And of course, Southeast Asia region bears major proportion, 88% of the burden. Interestingly, the highest burden is due to stroke, followed closely by all cancer, different types of cancer. And because the problem is more among women, the proportion of deaths was higher among women. all cause, all cancer, and ischemic heart disease mortality, all these regions. The disability adjusted life years have also been estimated and have been reported to be about 46 million due to all causes, and major share of it again comes to Southeast Asia region. And if you look at the causes, it was majorly for all cancers and for stroke. And again, Delhi was higher among women for all cause, all cancer, and ischemic heart disease. The process of recognizing SLT is an important component of global tobacco control, but that has been slow and laborious. But it may be the single largest risk factor for intervention in the prevention of about 650,000 deaths that we have seen, that constitute about 10% of all tobacco attributable deaths. Now for India, we have much more, problem is much more data are available. So in fact, more analysis has been done. So observed relative risk for males and females, 1 point separately, 1.34 and 1.17. You see much higher for females than among for males. And taking the estimates of smokeless tobacco users prevalence and these relative risks, we can estimate the deaths attributable to smokeless tobacco use, and that comes out to be 368,000. That is more than 200,000 men and about 150,000 women. So you see again the problem is much more higher among women, and these deaths are among non-smokers. These have been calculated for non-smokers, and that is because data were available for India. And these estimates call for targeted public health intervention in India focusing on smokeless tobacco product, especially among women, because they are bearing a major brunt of these health consequences. Now, I talked about adverse pregnancy outcome. There are by now several studies. We started with one, I started with large cohort study in Mumbai. Then there are many other studies which have consistently shown that smokeless tobacco used by pregnant women causes low birth weight, preterm birth, and stillbirth. And odds ratio was significant in our study for all three outcomes, 1.88, 1.39, and stillbirth 2.85. And looking at different studies, one can do meta-analysis and compute the overall estimates, and if we use them, we find that about 870,000 low birth rates in India every year are due to smokeless tobacco use. About 190,000 preterm births that occur in India are attributable to smokeless tobacco use, and 120,000 stillbirths that occur in India are due to smokeless tobacco use. So smokeless tobacco use by women is a major problem for reproductive health in India. So the evidence is quite enough, quite sufficient, and SLT has really been not given as much attention as it should be. And I think the estimates are now reasonably quite robust. Of course, we don't have as much data as for cigarette smoking, but now I think we have enough data to pay attention to this problem, which is still growing. And with the major burden in poor countries, LMIC, Southeast Asia, and higher burden mortality as well as diseases among females and other vulnerable groups like poor person, the fight against smokeless tobacco becomes even more important. And of course, there are challenges in these fights that is not a priority in tobacco control arena all over the world. The data are still limited, economic data are limited. Product diversity, we are not dealing with one product, we are dealing with multitude of products, and in fact we are dealing with tobacco not even as a product, but as an agricultural produce. So controlling that presents a huge amount of different kind of challenges. Diversity of product, and to compound the problem, new products emerge in the market. Like we saw Gutka, pan masala, and now these toothpicks and herbs. And knowledge about the harm of smokeless tobacco is much less. In fact, there are a lot of misconceptions still in the population that smokeless tobacco use is beneficial for health. In terms of many problems like stomach problems, and especially for oral health, it is good. And that is how there are so many products especially designed for use on teeth and gums to take advantage of this misconception that smokeless tobacco is good for oral health. And there is still a section of public health health professionals who may advocate that smokeless tobacco is important, is good for harm reduction. Of course, in India, it doesn't work at all, but in other places, the argument can still be there. But smokeless tobacco is an additional problem rather than harm reduction problem. So I think I will stop here and pass the mic back to Professor Ravi Mehrotra. And thank you very much for your attention.
Thank you so much, sir. That was a bird's eye view of smokeless tobacco, as well as that really helped us in setting the stage, what the problem basically is, how widespread it is practically all over the world, and at the same time, what are the high burden countries which need to be focusing more and more on the existing problems. And it could be an epidemic which could affect the countries which are not, who do not have a serious problem as yet. With smoking, public smoking at least going down, one might find that people take on newer products, as you are probably well familiar, be it the electronic cigarettes or the non-combustible tobacco, and chewing tobacco could actually see a return or could see a sudden rise in many countries. So that is the reason why this global interest is there from so many different parts of the world. So my job for today is going to focus primarily on what are the policies at the present moment, what are the gaps in policies, as well as what can be done for better implementation. As I had mentioned earlier in my talk, I represent the National Institute of Cancer Prevention, which also is a host to the Global Knowledge Hub on smokeless tobacco, as mandated by the WHO FCTC. So we have recently launched a report on the global smokeless policy, control policies, as well as the implementation, and this is available on our website. This is at the bottom of the screen. You can see the web link, and our team will share it with you again, so you need not bother about writing it. And of course, we will also hopefully share the PowerPoint if you can send us your email addresses, and we'll be more than happy to share both the presentations. But Gupta, I'm sure we have your permission. Yeah, sure. So this is the first attempt to present the progress on control. It was mandated at the 6th session of the Conference of Party from FCTC, which was held in Moscow about 4 years ago. The last session, the 7th COP, which was held here, right here in Noida, outside Delhi, it was reaffirmed, and we could actually launch the COP as such. And we got together a wide panorama of experts, not only from the country, the high burden countries, but also a lot of our compatriots and a lot of our experts spread all over the world. To support it to a large extent by the WHO FCTC Secretariat based in Geneva, and information was compiled vis-a-vis the WHO FCTC protocol. The scope of the report included a comprehensive global review of current knowledge through a standard method. Within this institute and as collaborators, we reviewed it thoroughly, and also we sent it to two external independent collaborators, not only in high burden but also in low burden countries outside the hub as a peer review. We compared similar indicators for cigarettes as well as SLT products for better understanding. We highlighted the issues specific to SLT in high burden countries, looked at what are the opportunities and challenges related to specific articles of the FCTC, how implementation of the research gaps and the existing policy gaps are possible, and at the same time, we gave recommendations that are based on scientific evidence and lessons learned not only by the high burden, but also low burden experts, low burden country experts. The articles which were included, I will not take you through all of them, but I will just maybe go 2 or 3. Could I please request you to mute your microphone? Thank you so much. So we focused on roughly 10 articles which were pertinent to smokeless tobacco, looking at price and tax measures, especially looking at education communication strategies, ban on advertisement promotion, that is TAPs, how we can look at access and availability of these products to minors, as well as how do we exchange information between various countries, looking at research, how to implement the ban, as well as prohibition of import to countries which do not produce. For example, in the neighboring country of India, in Bhutan, none of these smokeless tobacco products are produced, but to a large extent they are exported to our neighboring countries. So these are the kind of things which are, of course, important and need to be focused on. Regarding the source of information, we looked at tobacco control legislations, including the country's website as well as the tobacco control websites. We looked at the FCTC reporting instruments, for example, in 2012, 14, 16, and now we are hoping the 18 instruments should be available shortly after the next COP8 meeting in Geneva. We looked at the WHO report on the global tobacco epidemic of 15 and 17, especially with the Empower being emphasized. We looked at the WHO SLT survey report, and we also looked at various global, regional, and country level SLT control report where it's possible. And of course, we did a thorough review of various peer-reviewed articles. As Dr. Gupta has already mentioned, just to reiterate the point, the high burden countries have more than 1 million smokeless tobacco users. And the maximum, of course, is in India and Bangladesh, which constitute practically 70 to 75%. And if you include all the countries in the Southeast Asia WHO region, this year is about 80%. So the rest 20% is actually spread over nearly 140 different countries. The high burden countries are home to 95% of the smokeless tobacco use, which is a very sorry figure because most of these countries are located in regions which can least afford to have this kind of burden, already plagued by lack of awareness, education, various diseases, as well as lack of opportunities. So this is an epidemic which is unfortunately upon us, and that is the reason why we decided to focus on this particular topic. Article 1, when they talk about what are the proportion of parties defining smokeless, practically 62% of the parties especially included smokeless tobacco as their burden, and the rest of it, starting from generally included is in orange, gray is in obscurely, while a good quarter, that is 25%, they did not define what is smokeless tobacco in their policies. Another important area I want to talk about is smokeless tobacco taxation. As you are well aware, the WHO and various other experts explicitly talk about as a single most preventable measure that can prevent the prevalence and that can curb the prevalence of tobacco is taxes. So we wanted to look at what are the prevalent taxes in various parts of the world. Is this an effective tool to reduce the consumption? And tax increases have been effective in reducing, albeit a very small percentage, in the highest of the burden parties, that is India and Bangladesh. It has been shown in successive GATS analysis in India, that is 2010 and 17, as well as the ITC surveys in 9 and 12 in Bangladesh, that there is a significant reduction in the prevalence, especially in the general adult population. The significant tax increases have also occurred in this period in both India and Bangladesh. In India, it was found that increasing the price may discourage the SLT use, especially in men and youth. Unfortunately, the same decrease was not so significant in women. However, it's a good start. When you look at regulation of SLT products, the parties require the display of qualitative information on tobacco packaging. This is present in the first part of the graph. When you look at cigarettes and you look at SLT, this is the higher and upper middle income countries. On the right side of your slide, you can see the same story regarding cigarettes and SLT in lower and middle income countries, and you compare it globally, there's a world of a difference. The height of the bar diagrams is obviously far lower, and it is far more important. The less amount of information, the take-home message from the slide is that information can be significantly increased, especially in lower income countries, and that is where the problem is. So it is extremely important that product regulation comes in as far as policy is concerned. This should be made mandatory. For example, in India, smokeless tobacco also is considered to be a food product, and just like in other food products, you have mention of the quantity of various constituents. Similarly, I think as far as regulation is concerned, it will be a very strong recommendation from the hub and various interested experts that the product should definitely mention what are the constituents as compared to the global scenario. All over it is weak, but more so in these specific high-burden countries. As far as the health warnings are concerned, the two graphs, the blue is cigarettes and orange is smokeless tobacco. It doesn't require to be expert to see that the progress in notifying health warnings, that is any warning which is more than 30% or 30% or more, is much lower in smokeless tobacco. In India, we have recently introduced in the last few years 85% back warnings. Initially, they were only for cigarettes, and now that has been also introduced for various smokeless tobacco products. And we hope that this will be followed not only in India, but also other countries where they do not exist so far, thus increasing this particular approach of at least warning those people who are literate, who are illiterate, who may be able to not read, but they are very, very prone to see this warning and hopefully will be dissuaded from starting or keep on using it. Next, I want to talk about the percentage of smokeless tobacco users who thought about quitting. We have this recent information from the GATS 17 as compared to 34% In 2010, we're talking about SLT prevalence of 26%. Now, in the most recent gap, that is 2016, released last year, the prevalence had come down to 21%, but 46% actually had this knowledge and who thought about quitting after seeing the warning. So we have reasonably good evidence that these warnings do have an effect. Many of you may have seen these warnings. They started off relatively benign, saying that tobacco kills and showing the crab, which is a sign of a cancer. In 2012, they were increased, and the most recent 85% warnings, they became 40 and then 85%, show obviously ghastly sight of the entire nose, the face, and the lips being practically eaten away by cancer, which is caused by smokeless tobacco. So, if I were to extrapolate, increasing the size and increasing the quality of the warnings have resulted, at least be partially responsible for decreasing the prevalence from 26 to 21. I know 5% doesn't sound a lot, but when you talk about the population of nearly 1.3 billion people and the huge number of users, it is a very significant form. And so also, we conclude that back warnings are useful. In spite of the naysayers, we would like it not only to remain at 85%, possibly go up, and also be rotated depending on various researches and surveys that are done. When you look at mass media programs in India, the Indian government airs these campaigns, be it the Mukesh campaign or the Sunita campaign, and various other media spots that are used looking at dangers of smokeless tobacco. These are the ones which were found to be really useful, and we are looking forward to more such media programs using the television, using the big screen, that is the movie screens, as well as now social media, which is of course gaining more and more importance. Nonetheless, it would be silly not to evaluate the campaigns, and after evaluating, our colleagues from Wider Strategies and various other institutions have concluded that 63% of smokeless tobacco use and 72% of dual, that is with tobacco, recall the campaign. Over 70% of them said that they made them stop and think, and also it was providing new information to many people, and they started thinking. 3/4 of smokeless and nearly the same of dual users said that it made them feel concerned, made the families also aware that smokeless tobacco is not a benign, not an innocuous use. So this campaign awareness is associated with better knowledge, more negative attitudes towards SLT use, as well as a greater cessation-oriented behavior. And hopefully, many more will be inclined to think about not using it in the first place, as well as cessation and stopping use completely. An important topic that we always felt that has a lot of implication is looking at the ban on tobacco advertisement and promotion. The free distribution in mails or by personally handing over samples, of course, is more in cigarettes as compared to SLT. Since the complete ban on sponsorship is there, at least in countries like India and many other in the neighboring areas, it has actually remained practically static. Between cigarettes and smokeless, it is between 47 and 46. But the distribution, unfortunately, is also there, but less than cigarettes. Talking about cessation, as far as the global availability of quitline is concerned and nicotine replacement therapy, the blue bars represent quitline and the magenta or red is replacement therapy. As you can well imagine, the figures are obviously better in high-resource countries. For NRT, it is 85 as compared to 49 in low-resource parties. And for cigarettes, it is 39 and 21. So this slide emphasizes the huge gap between smoking and smokeless, and also underlines the fact that we have to be focusing more on, now that so many people are keen to quit, how to help those people. And SLT cessation is a very burning concern, not only in some of the high burden countries, but also some of the newer countries which are adopting smokeless tobacco and needs fair amount of not only money, but also development of expertise. We in the Government of India, the Ministry of Health and Family Welfare, started end cessation in 2016 in collaboration with the WHO. And within a span of 1.5 years, we had more than 2 million tobacco users which were enrolled. The quit rate between 12,000 registered users who followed up was actually 7% for both smokers and SLTUs at a 6-month follow-up. Now, 7% is not a huge amount, but it is far better than earlier on. We also have an interactive voice response, IVR scheme in English and Hindi, and hopefully it will be expanded to 5 additional languages and slowly cover the entire country, where practically 26 languages are in vogue. Another important issue which affects not only India and Bangladesh, but many other countries, is looking at the minors' access to smokeless tobacco. We found that complete policy of banning sale to minors was present in 21 countries for cigarettes and 18 for smokeless tobacco. Vast majority had only a partial policy, that is 120 and 102, which can be seen by the lighter blue bars. And of course, 38 countries had no policy. On the other hand, 58 had no policies as far as SLT or smokeless tobacco is concerned. This slide emphasizes primarily the importance of having a more complete ban on sale to minors. We are hoping to start to end shortly. Kindly bear with me. This rather busy slide talks about the various articles and the number of parties which are endorsing it. I will not take you through details, but anybody is interested can have a look at our website and the PowerPoint. This is really our last slide. Thank you so much for your kind attention, and I would like to leave a few minutes for question and answers. Thank you so much for your kind attention.
Those who have questions to the experts of the session, please raise your hand digitally or wave out to us and we will let you ask your question.
I can understand it's the first webinar. People might have some problems in.
Yes, Dr. Bojani, please unmute and ask your question. Dr. Bojani?
Yes, yes, thank you. It was wonderful to hear from both the speakers. And I appreciate to receive the presentations. My specific questions and a comment. First to Dr. Gupta, I think it was wonderful to learn about very many different products. One thing I would like to know more is, do we know enough, or at least do we have some knowledge around the smokeless tobacco industry? Because I think that's one thing I kept longing for to understand more. So maybe your comment on what sort of literature is available and what kind of efforts are ongoing or we need to invest in to better understand the whole smokeless industry. And one more question to Dr. Mehrotra is when we compare, and this report was very useful, but when we are comparing the compliance, legal compliance, for example, across smoke and smokeless products, I'm wondering whether sheer widespread geographical spread of smoke products would actually mask the data. So for example, if you only compare smoke and smokeless tobacco products within South Asia, I'm wondering whether that would be more meaningful, when we look at comparative statistics across these two kinds of products. Thank you.
Yeah, thank you, Dr. Bhojani, for your very pertinent question. It is a problem. And as I said in my presentation, smokeless tobacco products are made in many different ways. And they can be made by a user, they can be made by a vendor, they can be made in very small scale cottage industries. And then there are few products that are made in large scale, big industries. So a study of the smokeless tobacco industry is quite, in fact, difficult. It's not as easy as the study of cigarette industry, where we know that in India only two major players are there, and there are 2-3 others players. And as I also remarked, there is very little research, very little data on economics and industrial aspects of smokeless tobacco products and smokeless tobacco use. So that is still a huge gap that we need to fill, understanding the smokeless tobacco industry like we have quite a good understanding of cigarette industry. Dr. Mehrotra.
I quite agree with you, sir. Since it's such a huge number of brands, unlike cigarettes where we know there are 3 or 4 major brands available, for example, in India and similarly in various other developed countries, smokeless is a huge industry. I mean, about thousands of different products. Many of them are unregulated. They may be made as a cottage industry, may be made in somebody's home or in your neighborhood. They do not even have a brand name. And to understand all these various procedures and all the various protocols which are even made, which are used to primarily distribute them is a totally different ballgame from cigarettes. So I really wish we had an easy answer to that, as you know, what we understand about the industry. We all know that there are 4 or 5 major players as far as packaged smokeless is concerned, which may be also regional. They may be different in the west of the country or in the south of the country as compared to north. So we still have to come to grips with that. But the question that I was supposed to be looking at was, as compared to cigarettes and smokeless tobacco, how do we compare between different countries? As we have tried to do it in the policy book, you might actually see a difference between the smokeless tobacco products and the cigarettes. But thank you. So as you can see, given such a huge variety of smokeless tobacco products, comparing it with the organized industry like cigarettes is a very difficult job. But we would, as a matter of fact, as we speak, we are trying to make a compendium of all smokeless tobacco products available in the high burden countries. For example, India, Bangladesh, Sri Lanka, and Pakistan, Myanmar. But it's going to be a huge task, and since we are just starting, I hope and pray that given a year or maybe 2, we'll have a partial answer to what you are talking about. But at the moment, I fully agree with you. It is a difficult job, and it's going to be require all the resources that one can possibly think about. But thank you for asking that question. I think that's an extremely pertinent issue.
Dr. Sachin Partha had a question. Please go ahead, unmute and ask your question. Please go ahead, Dr. Sachin Partha.
Ravi sir, good afternoon sir, this is Dr. Gogoi this side. Dr. Gupta sir, this is Dr. Gogoi.
Yes, Dr. Gogoi from Guwahati.
My issues are very specific, sir. Now in northern state, any states, like in Mizoram, like in Manipur, not Assam, Nagaland, we are finding some local type of Gutka, which contain all mixture of turning. But we say, are you hearing me, sir? Are you hearing me, sir?
Yes, yes, I can hear you. Go ahead.
So now issue that whether we have done any survey on this part, sir, because we know lot many Gutka things available in the market, like Gupta sir has given all detail, but something local Gutkas containing tobacco and the SLTs. Is any study and survey on that part, sir?
Okay, Dr. Gogoi, what I understand is in certain parts of the Northeast, they are local manufacturing of Gutka, which may have very different constituents. You
Yes,
want to
sir.
know whether there is a study that is ongoing at the moment. Is that the question? Dr. Gogoi? You seem to have lost it. Well, the answer is there is a lot of stress on the Northeast as far as smokeless tobacco is concerned, since they have a very high prevalence, lot of varieties. Studies are planned to look at specific smokeless tobacco products coming in from the Northeast, be it Meghalaya, be it Mizoram or Assam, your state. At the moment, now that we have testing facilities, we'll be looking forward to getting samples from those areas, and we'll be able to tell you both in the Guwahati lab or Bombay lab or the one that has just started in Noida, to be able to analyze those samples and decide exactly what they contain. But I think that's a very important point that you have raised, that in various parts of the country, the variety of smokeless tobacco products are so varied, it is important to get a handle on them.
Yeah, let me just add to what Professor Ravi from Mehrotra has already said. Of course, in Northeast, as you say, there are very specific local brands of not only Gutka, but other tobacco products also. But the same is true of every part in India. There are local brands which are marketed and popular only in those areas. There are some brands we know which are national because they get advertised on TV as surrogate advertisements and even by big Bollywoods and celebrities. So those are kind of national brands, but there are in every area we find that there are local brands. And what ingredients go into those brands, nobody really knows. And even if you ask them, or there are anecdotes and stories that even workers working in those factories are making Gutka would not want to talk about it. That what are the kind of things that go in those products. So as Dr. Mehrotra is saying, we are very much looking forward to this facility of laboratory testing smokeless tobacco products, where they would be hopefully testing many different kinds of products.
Thank you very much, sir. Thank you very much, sir.
Does anybody else have any questions? Please unmute and go ahead and ask your question. Turkmenistan has raised their hand. Please go ahead and ask your question. Turkmenistan.
Hello.
Yes, we can hear you. Go ahead.
First of all, I would like to thank you for your. Thank you. I would like to thank you for your productive, very useful presentation. And I have a couple of questions. Maybe I missed it during the presentation. The first question is, do you have any smoking cessation centers? And if so, do they treat consumers of smokeless tobacco? And do you evaluate the service of this center? Thank you.
In fact, very good question. But in India, as we find the major tobacco problem is smokeless tobacco problem. So any cessation centers that deals with tobacco cessation will naturally have to deal with smokeless tobacco cessation also. Most of the strategies that are used for cessation in the clinic situation also are generally counseling and behavioral intervention. We have some clinical trials, but not a great deal of data on pharmacological intervention of smokeless tobacco cessation. The data are far more for smoking than for smokeless tobacco cessation for pharmacological intervention. Maybe Dr. Mehrotra may have more information on that.
The vast majority of studies that have been done so far in SLT cessation have actually come in from the US. There are a couple of reports from the developing countries, but that is one area which the Smokeless Tobacco Hub and its collaborators is very keen to get into. There are talking about short counseling, talking about various pharmacological interventions or medicines like glucagon or beryl. It is also one of our aims to look at various systems of various medicines coming out of the Indian system of medicine, whether they have a role to play. But these are all experimental at the present moment. And also look at various approaches like meditation and yoga, which again come out of the traditional systems of medicine. But till we come up with some random control trials, it will be too early to come up with conclusions. But I really like your question because it is so pertinent that at least in most of the developing and high burden countries which have a problem, you have to combine tobacco with smokeless tobacco cessation. And this is an area of which is high priority, which has been identified in the recommendations in the policy book. And hopefully, as the years go by and more people are sensitized to the fact that this is a very high priority area, we'll have more answers as we go on. Thank you so much for asking the question.
Rumana Haq has a question. Please unmute and ask your question.
Excuse me, you forgot about my last question.
For this nice presentation. My question is, has there been done in India of tobacco use? What are the determinants that increases the dependency? For example, is there a variation across the product, or if people consume more, they become more dependent, or whether swallowing the product increases the dependency. So has there been any study done in India on this issue?
That's very interesting question, extremely interesting, and especially in view of the wide variety of products. So the dependency, we know that depends upon the amount of free nicotine, unprotonated nicotine that is available in the product that can be absorbed by the user. And in smokeless tobacco products, that is adjusted by pH, by adding alkalinity to the product. So almost all smokeless tobacco products have some alkaline agent to control and change the pH and increase the amount of unprotonated or free nicotine. So depending upon that, the level of dependency and level of the amount of use that will involve dependency would be different for different products. Some evaluations have been made, like how much pH is there in different smokeless tobacco product and how much is amount of free nicotine that is available, and it varies a great deal. There are several reports and it varies a great deal. So that is how the effect, dependency effect of different smokeless tobacco product also varies quite a lot.
Do you have anything to add to that?
I think, Romana, we all know that given the huge variety, we really have miles to go before we can actually be sure that what is the dependency. And also, as hopefully we'll be able to standardize things, it might be easier, but at the present moment, that is the state of the art.
But just to clarify, practically all products do cause dependency, because we see that most users are daily users, regular users, multiple time users. So obviously that is, although even if we don't have a great deal of study on the dependency scales data, but just by observation it is clear that there is a huge amount of dependency practically on every kind of smokeless tobacco product.
Thank you, Romana, for asking the question.
Turkmenistan, it looks like you had a part of your query that was unanswered. So please unmute and ask the same.
Yes. Sorry, I think that you just forgot about my third question. Do you evaluate these services? I'm sorry.
Services.
You don't understand. I mean,
Okay. Well, there is. Yeah, go ahead. Please finish.
Okay, she's ready for your answer.
Okay, we do have cessation services, although they are few and far between in many parts of the country. We have an M cessation, as I talked about, which is quick line available pan-India. But as far as individual cessation services, all dental colleges and a few medical colleges, including some of the government hospitals, have cessation services. But they are patchy in number and distribution. The ones that are there do report that practically 50 to 60%, sometimes more, of the people who want to quit have a problem with smokeless tobacco. But as I mentioned earlier, we are really looking forward to getting more controlled data, which can, in an unequivocal and a robust, give us some robust evidence to be able to support which particular strategy works the best in smokeless tobacco. I hope that answers your question, and thank you for asking me.
Do we have any more questions from our participants? Please unmute and ask the query. Yes, Maya, please go ahead and ask your query.
Yeah, about the advertisement of the product. My name is Chandar. I represent my organization called Maya. They're blurring even the cigarette. The established tobacco company, the visuals are not very clear. The warning, they're blurring. On the chewing tobacco, it's worse. How to address? They deliberately blur the images. It defeats the purpose.
No, that's a real, you have raised a very pertinent issue, very important. We all see that the warnings that are printed on smokeless tobacco products are not clear. They are fudgy, they are not of the same size as required, same combination. And there are now data and studies coming out to the extent of this non-compliance or partial compliance with the warning requirement. And hopefully we will see in near future, we should see some action. One problem with the smokeless tobacco products is non-standardized packaging. And generally, these are single-use packages which are very small. So the printing of warning itself, they can take a considerable amount of leeway in printing that warning. Unlike other tobacco products, like especially cigarettes, which are sold in packages, smokeless tobacco products can be, are often in fact sold in single-use format that have very small weight and very small package, and that kind of makes it difficult to visualize the warning properly. So that is definitely an issue that needs to be addressed.
Okay, I think that's important. There's a comment from Dr. Rakesh Mahajan from Punjab, and with they talk about suspected samples, in which they checked for violation whether they have tobacco or not, and practically half, that is 800, failed the test, and court cases have been launched. this is an initiative coming out of Punjab, which is one of the more proactive states in India, in which they did use some laboratory testing and practically found that half the samples which were labeled as not containing nicotine in any version did have nicotine. So thank you, Dr. Rakesh, for sharing that information. And I'm sure as testing facilities improve, not only in India but other parts of the world, we'll be able to definitively get hold of these violations and be able to act accordingly. Thank you so much.
Does anyone else have any questions?
It is 5:50 IST. I think we could wrap it up.
Yes. If there are no further questions, then we will call it a day. Thank you all for attending this session. Thank you, Dr. P.C. Gupta and Dr. Ravi Mehrotra for conducting this session. And most of our participants have commented in this chat section that they absolutely love the presentation and have requested for the presentation to be shared in emails with them. So all of you who have shared your emails, we're going to share the presentations with you. Like Dr. Partha, Dr. Gogoi has one last question. So we will let you go ahead. Please unmute and ask your query.
Thank you.
Go ahead, Dr. Gogoi.
No, I said thank you. I just said thank you very much. Thank you very much. We'll have more such interaction, Dr. Ravi. We'll have more such interaction to help us, everybody.
Yes, Dr. Gogoi, thank you for your enthusiastic support. And the plan is to have at least 6 more webinars on different aspects of smokeless tobacco before the year is out. And also, I personally thank Dr. Gupta for joining us here, especially on the occasion of the World No Tobacco Day, which was yesterday. So all of us, this would be a good way to commemorate by launching of this webinar. And we'll be looking forward to a lot more people joining. Today we had about 50 participants, which is encouraging to say the least. And also, we would like our participants to not only present their own findings as we go along, but their own case reports, their own experiences, and so that we can learn from each other. Thank you so much once again.
Yeah, and thank you, all the participants for logging in, making this session so interactive, and really asking some very pertinent and good questions. So thank you all very much for your participation, which made our own presentations and conversation here quite interesting. Thank you all very much.
Thank you.
Congrats.